right. Hello, everybody. Hello, Dr. Hacker. How are you tonight?
I'm well, thank you very much. I appreciate being here today.
Thank you so much for saying yes to this. As you know, it's Endometriosis Awareness Month. It's a topic and a cause that's dear to my heart, and especially as someone with POTS and hypermobility syndrome, I feel like the pelvic vein component of chronic pelvic pain is completely underdiagnosed and overlooked. So I really wanted you here tonight to give us a little bit of a lesson about what could be happening in our pelvises that could also be contributing to chronic pelvic pain and cause a bunch of other systemic symptoms. So, yeah, thank you so much.
Yeah, absolutely. So I personally feel that this is kind of the hidden component
Hmm.
that's being missed in a lot of patients with the diagnoses of POTS, dysautonomia, pelvic congestion syndrome. And many people have these. Some people don't have this.
Hmm.
And so I think it's very important to start off with, a thorough workup by the OBGYN,
Hmm.
and the PCP is very important. There's a
Hmm.
lot of women who are suffering from pelvic pain and may have something benign. And when I mean benign, I mean, okay, you have disc pain, discomfort from the endometriosis. There are people who have cancer, ovarian cancer, uterine cancer,
Hmm.
GI tumors. So I can't stress enough, initially just starting off, that I know we get into the mindset, I have POTS, I have dysautonomia, I have hypermobility, but
Hmm.
there's some very real pathologies that even young people can develop that we should
Hmm.
always make sure that we get from the gynecologist
Ruled
first.
out. Yeah,
Yes, rule
absolutely.
out the basics. And the cancers today in 2026, we can detect them early. We have treatment for our children now to prevent future generations from getting them, but they're so easy to identify with modern imaging
Yeah.
that we have to take those off the table first before we go the next level, which is what we're here for today.
Yeah, yeah, absolutely. And I just wanted to say to everyone who's here, I have the chat box open, and I really would love if you have any questions. So please keep your mics on mute. But if you have any questions that you'd like to ask, please just pop them into the chat box, and we'll see if we can get to them a little later on. So yeah, I will do a little note in the chat box. So um, collect your thoughts and questions and put them in there. That would be great. But before we kind of delve into the nitty-gritty of what these conditions present like, I'd love to ask you, Dr. Hacker, if you would do a little anatomy lesson for us. So I'm just going to share my screen and and give you remote control. Hang on one second.
Great. Yeah.
And I'm just going to share your Instagram. And if anyone here isn't aware, Dr. Hacker's practice's Instagram is um, up on the screen. So you can follow that account if you're on Instagram and you'd like to see more about what he does in clinical practice. So yeah, I think you've got
Yeah.
access to
Thank you.
my mouse now. So please take it away.
All right. Is it moving? All right. So I'll start off with, I'm a terrible Instagrammer. I do it only because I have to, and it's been a good way to connect with patients, but this is not my primary thing
Of
since we kind
course.
of run the practice. But this photo I put up a long time ago, and it actually really makes a lot of sense. And so here's some very basic anatomy. For some background, I'm a vascular surgeon. I practice in the United States. I'm in the state of Missouri. I practice throughout the country. I have two board certifications, one in general surgery and one in vascular surgery. So I have actually been in this space. I have touched these organs. And so I think that provides a really great next level appreciation for what's going on. This is very three-dimensional. And
Yeah.
honestly, I think this is one of the reasons why it's been missed for so long.
Mm.
And so let's go into it. So the basic anatomy, and women are usually very well adept at this point. They've done a lot of research, but I'll do a refresher for you.
Yes,
So of
please.
course we have we of course have the heart, and the heart brings blood through the aorta, which is the large blood vessel. We'd be looking at the U is about the level of the belly button if you were looking at somebody. And of course, on the left side of the body, you have one kidney in the normal person and a kidney on the right. And you have two very interesting phenomenon that I think are very important for the EDS, POTS, dysautonomia, pelvic congestion syndrome community. And it's the fact that you have one big vein going to the heart, one big artery coming from the heart, but they have to cross to get to both sides of the body. This leaves two potential compression areas of significance in this group. One is the nutcracker phenomenon, which is right here where the superior mesenteric artery, this blood vessel, which
Just
is
give me one
responsible
second.
for,
I'm not sure if your mouse is moving on the screen. Can you just test
oh
that?
no, here, you don't see me moving.
No,
Okay.
just give me one second. Let me. Oh, there we go. There we go. Yep, perfect.
Okay, I'll do this.
Yeah.
So we have the aorta coming down, splitting to the iliac arteries, and then we have the inferior vena cava going back to the heart. We have right here, first compression area, and this is the left renal vein going to the left kidney. And this creates compression from the superior mesenteric artery right through here. And the superior mesenteric artery's responsibility is to feed the intestines, the right colon. So it has a lot of weight to it, a lot of flow through it. But this kidney vessel runs underneath it. And in some people, people we find with EDS who are thin, who have small angles, this creates a compression point. I will get to this, why this is important.
Okay.
The second compression point we see is down here, where the right iliac artery has to get to the right leg, and the left iliac vein is draining. And unfortunately, the artery, the heavier, stronger object, is on top. This is about the segment where the sacrum begins as well. And so usually in the pelvis, you'll see a drop and then you'll see a drop off into a curve. But these vessels can migrate in various levels of patterns. And in some people, you'll see this compressed. And we'll demonstrate why that's important.
Yeah.
In the 60s, this was described as by May and Thurner as the May-Thurner syndrome.
Mm-hmm.
And it was appreciated to be relatively observed in the community, maybe at about 17% of the walking population. Nutcracker phenomenon is with compression is identified, I think, reported around 12%. But in the EDS, pelvic congestion syndrome, we see it 95% of the time. It's extremely
Yeah.
dominant to the
Yeah.
point where I think that everything has changed and the papers need to be written.
Yeah.
So
Yeah. Yeah.
So, so what I have identified, I love the little faces. What I've identified is by sheer accident is that by treating this for normal varicose veins, people were saying their POTS and EDS symptoms were getting better. And then that led us down over the last 18 months, this rabbit hole where we identified patients actually seeing this pattern more and more and more, this occurring more and more and more, and then suddenly realizing that in fact, maybe we have found something that's been missed the whole time.
Yeah. Yeah.
So, so what I was hoping to do now was let's go to the next page and I'll show you
Yeah.
what ovarian vein and
Okay.
pelvic congestion can look like. These are not new disease processes, pelvic congestion syndrome, ovarian vein reflux. Um, we'll go to the other screen with the
Okay. So,
slide earlier, and then we'll come back to this. Yeah.
great.
So
So,
these have all been described for years. People have known that they've been present, but I think the big piece is no one has understood how they all connect and how everything goes.
hmm
You can see here in the United States, the Society of Vascular Surgery, which would be considered the kind of prominent vascular society in the United States, identified and even classified your symptoms, how
mm,
big your varicose veins are, and what is the anatomic cause of everything that you can see here. And they came up with a classification system, which is what the American medical societies like to do. But it doesn't change anything. I do think that maybe starting to utilize this more might help people communicate how bad their symptoms are. It'd
yeah.
be very interesting to see where people classify,
Mm,
right?
yes.
Um,
Yeah.
and if people don't know what venous claudication means, it means that if you were to walk, your left leg would start to feel heavy and
Yeah.
full and uncomfortable as the blood starts to accumulate in your leg and cannot drain. So that's what venous claudication
Mm,
is.
yeah.
Uh, and then, of course, you can see there's various levels of symptoms either in the pelvis or in the genitalia.
Yeah,
Uh,
because you can experience like vulvar varicosities too, can't you?
Correct. And
Yeah.
actually, the very classic is if you have left-sided vulvar varicosities, you have this compression syndrome.
Very
In
interesting.
gentlemen, the term would be a varicocele and be on the left side of the scrotum because the body is literally split in half based on how the veins drain.
Yeah.
So we have a definition of the varices, where they are, what we feel, and then of course why they occur for the etiologic. And I think this is probably the weakest. This over here is probably the weakest of all the descriptions.
Hmm.
If we scroll up a little bit, we'll zoom in, and we have this great photo here, and we can
Yes.
really look at everything. So now we've talked about the areas of compression up here on the left kidney. It's kind of highlighting, it's okay. And then we had a little compression here over the left iliac vein. Well, I think what's been underappreciated is how much those compressions matter. Um,
Mm.
because if you think about blood, blood is always trying to get back to the heart. If it experiences a compression, it's going to go through the path of least resistance.
Yes.
So this is where the ovarian vein, and I think this is where the medicine has maybe broken down or not put all the pieces together. If 25% of your heartbeat goes through both of your kidneys, that means each kidney is getting about 12.5% of the blood flow, right? And so if you have, right where it says left kidney, a narrowing from the superior mesenteric artery, and 12.5% of your blood flow can't get out, what's it going to do? It's probably going to develop another way to exit
Yes.
the body.
Yeah.
And so we've identified two or three patterns, and there's probably more. We just haven't looked at them because it's actually hard sometimes to get the catheters where you need them for the dye. One is
Mm.
around the stomach. We think that's where people get gastroparesis.
Yeah.
One is through a secondary venous drainage around the spine. We think this is causing the headaches. And the other one is through the ovarian vein going in the reverse direction to drain to the pelvis to try to get down here into the internal iliac vein and then tries to drain back out. And
Yeah.
that's where you get the ovarian
Yes. And
congestion.
that's what I had. Yes. So
Yeah.
that's what got coiled. Um,
Yes. Yes. And
mm,
so you'll see if you look at this picture here, you can see the female genitalia and system drains in several places, but one of them is through the internal iliac vein. And if you have a compression right here, right? Whether it be from a heavy uterus from multiple pregnancies for
mm,
multiple periods of time. So women who've had
interesting.
3, 4, 5, 6 children,
Yeah.
they may today look normal with no compression, but they had months and months and months of compression. This is how they drained their pelvis. It exploited all these veins and then it never came back. So if you have a connective
Right.
tissue disease, you may notice that a lot of veins stay distended. Some
Right.
women actually have persistent compression from the artery. And then to add insult to injury, if you want to get outside of today's topic of pelvic, just for people with POTS, we think that there's some interplay between the nerves, specifically the vagus nerve, the artery, and the vein, all working together, leading to dysautonomic dysfunction.
Yeah. I highly suspect that too. I mean, it would make sense.
Yeah, and so it's very interesting that what I've dubbed is double compressors are basically isolated their left side of their body from the right side of their body. It's very fascinating, and
Can
so
you
we found
elaborate
that.
on that a little bit? Can you,
Well, sure,
yeah, I
sure.
don't quite
So
get that.
if you have a
Sorry, I've just got to
compression
use the mouse
here,
for 1 second to let someone into the room. Sorry.
oh,
There,
of
sorry.
course.
There we go. Go ahead. Got it.
So if you have a compression right here,
Yeah.
hopefully it's moving again,
Yes.
and you have a compression right here
Yeah.
from the iliac, what you're going to have is your left leg is trying to drain. It hits a compression here, so it exploits the pelvis. And if you
Yeah,
have
of
a
course.
compression here, it exploits the ovarian vein, hits the compression a second time, and then exploits the pelvis. And so we find double compressors. So the whole goal that we've identified surgically is if we can place stents here,
Hmm.
stent here, and then appropriately coil, we can reestablish physiologic flow.
Interesting. So you still need to coil the ovarian vein even if that vein is dysfunctional due to the upper stream, like the upstream compression.
So you don't necessarily have to. You could probably make a strong argument. You could leave it and keep it as a parallel system. The
Mm,
small snafu is the best stent we found when it's placed in this region will never let you, the way it covers, you'll never be able to get into that vein again because it'll cover the origin of it. And so the fear is that if you don't coil it, once you've covered it, it either could pressurize itself,
mm.
or if it is symptomatic, you've completely boxed yourself out.
Especially
So
if
I
you've
made the
already got
decision,
bad connective tissue quality like lax and it's
correct.
super
So,
enlarged.
yeah, so we made the decision just to turn it off essentially and then
Yeah.
isolate this side of the body.
So what happens
But
to all of the collaterals after this has been fixed? Do they just kind of shrink back up?
yeah, the idea is you're never getting rid of all of them. We want to kind of reduce them, but we want to have as little pressurized blood flow through them as possible. I think you could make several academic arguments that you should leave them and serve as like a bypass in the event of an emergency. If you were, let's say, having symptoms young and planning on having other children, we might leave them open to allow pregnancy to progress normally. Might avoid doing any kind of renal vein treatments and just focus on the iliac vein stuff. The idea is we just want the blood flow to get to the heart easily. And if you're starving the body of the blood, you may be experiencing the other tachycardia symptoms, assuming you
Absolutely.
don't have POTS. Because
Yeah.
many of these women don't have POTS, but they'll say I have a racing heart rate, right?
Yeah. Yeah.
And
So
your
what
thighs, go ahead.
mm, sorry, what happens with the ovarian vein if it's coiled and they want to get pregnant and have another baby?
As far as we know, nothing.
Okay.
It's basically gone. It's non-functional and should have no future adverse effects, which is why it's so important down here. My coiling and treatment strategy is it's not a kind of take it all out philosophy, which is often the philosophy of the interventional radiologist. Mine is a light touch, making sure that we keep this internal iliac vein open so that you still get gonadal flow out of that ovary segment so that you can still get normal flow. Because in theory, if you congest it too much and you remove too much venous outflow, you can actually create such bad outflow problem that the organ will die, and it is a risk
Wow.
in over embolization.
Wow.
Yeah.
Okay, that's not good
So
either.
my philosophy is try to trim the tree down to the point where it looks like it's functioning normally and then walk away. The
Yeah.
body will usually take care of itself.
Yeah, okay.
So if we go to some videos, if people would like to see, just take a
Yeah.
look at this last photo one last time, kind of burn it in your mind, and then we'll go through some videos and I'll show you some real examples that we've taken in the lab on women.
Yes.
And obviously on Instagram, people can come back and review them themselves. We'll turn the
Yeah,
audio off on
I will
these,
share the videos now.
but
And
these are all dictated. So we'll start with this one. So
yeah.
this is a really good example. This is a two-part video, and you'll see we're here in the pelvis. I have no way to stop it, but you can see down through here. Here's her IUD. Is my mouse moving?
Yes,
Yeah, here it is.
yes. So you can
So
see the
so here's
marina in there.
yes. Oh, you can play. Okay.
Yeah.
So here you can see the IUD. So we know this is the uterus. This is the left adnexa, and this is the right adnexa over here. All right. We can see this catheter is in the gonadal vein. So we've gone up the right, across. Are you seeing it move right now,
Yes.
the mouse,
Yep.
as I go down?
Oh no,
Good,
press
down.
you want to press play?
There you go, as we come down here.
Yeah.
Good. So you can see the gonadal vein is quite large through this segment through here. But if you watch, you can see there's more contrast. Well, what are we seeing? Well, up here is the iliac artery compression, and you can see how dilated. But look, this contrast wants to leave that leg. See how it wants to go back? So if I coil everything and I take all these branches off, there's no place for the blood to go. So we
Right.
want to open this channel up here, right? And then we want to get rid of the gonadal. So when we go to the next slide, you can see this is a great example of someone with two things you can
So
see.
is this the
They,
same patient or a different patient? Different.
yes, all I did was slide up and did
Okay.
here you can see the renal vein. You can see the haziness of the compression, and you can see the blood's trying to get out. See how big and taut this vein is? This is very taut. And you see two
Yes.
branches. This is not well described in the literature, but if you follow it, it goes around and has a bumpy appearance. That's because it's going through the venous system around the spinal cord. It's exhibiting a pressure. And
Mm,
what do you think that venous pressure is going to do? Well, it's going to do two things. It's going to, if you're standing for a long period of time, imagine putting your hand in a bag and
hmm.
putting that bag in water. It's going to pressurize and push against the spinal cord. CSF is going to be pushed up to the head,
Headache.
and it's
Yeah.
also and headaches. And it's also going to press the nerves, discomfort. So that's one pattern that we've seen. So headache patients have this typical pattern. And then it has, look at the size of this gonadal vein. So when we stent it, we're going to cover all of this, right? We'll never be able to get into here, but we want to turn it off so it's not pressurized. And
Yeah.
so that's the strategy. So if you watch again, you can see now in real time, you can see with a better appreciation. That other hand is me dictating at the time
Yeah.
of the video. If we go to, let's see, this was our paper on nutcracker and POTS for people
Hmm.
who are interested,
Hmm.
trying to validate our research. We saw this.
So this is the iliac vein compression.
Correct. Yeah.
Yeah.
So let's see what this one shows. It's probably me talking. Let's see if it starts. Okay. Some of these get kind of long because they're very descriptive. Some of them
Yeah.
have the intravascular ultrasound. I don't know if this one has started or not.
That's all right. So what would be some of the red flags in someone with these conditions? What would,
So,
yeah, what should they,
yeah,
I mean,
a, a lot of the stories are the same. And so you'll get some of the things. Women of various ages, you'll see, here's a normal looking vein while we watch on the
yep,
right. See how quickly it flashes. So
yep,
you'll see women complaining of abdominal pain,
yep,
abdominal discomfort, pelvic fullness, pelvic discomfort, heavy periods.
yep.
Endometriosis is obviously the reflux of endometrial tissue from the uterus into the abdominal cavity. Uh, is this related? Unsure, but you could easily make an argument. At least I think that if you had a lot of pressure around the uterus, you do have something that could be creating a pressure that, aside from your own intestinal pressure and gas, that could be causing something that allow reflux.
Well,
So look at
yeah,
this video.
there is a theory of retrograde menstruation in the pathophysiology of endometriosis. Um,
Oh,
oh,
absolutely has to happen.
so
Absolutely
are
has to
you
happen.
drawing on your screen here?
So this is all from the videos on
Okay.
the Instagram. So you'll be able to see all of this. So all anyone who's interested can go back and refer to this, and it's describing all of this stuff in multiple patients over and over and over and over again. You'll see people who we've treated, who we haven't treated. This patient looks like they're getting treatment. So it's very informative. But what you'll see is a lot of the symptoms are pelvic pain, pelvic fullness, dyspareunia. I haven't fully identified whether or not infertility is an issue, but you will get some women say they had a long period of infertility,
I've
or
seen
they
some
had,
papers, interestingly.
mhm,
Yeah.
yeah, or you've had miscarriages, a lot of miscarriages, sometimes in the second trimester or stillborns,
Mm,
in the setting of no genetic abnormalities. Again, this is a hypothesis
mm.
of ours. Um,
I do have a
uh,
question about, you mentioned one of
yeah.
the symptoms being heavier periods. What,
Mhm.
how would pelvic congestion cause a heavier bleed?
Again, this is theory. I would have no way to prove it unless you did some very sophisticated manometry, meaning
Yeah.
pressure measurements. But if you understand that the way the human body works, it's all about gradients, right? Think of two things and think of a marble. So I put a marble on a flat table, it goes nowhere, right?
Mm,
But if I put it on a very high table with a steep ramp, it goes very fast.
hmm.
We call that level a diffusion gradient. This is a very simple way to explain it. So The way placental oxygen transfers, the way the oxygen transfers in our system, everything's about diffusion gradients. Well,
Yes.
the diffusion gradient, right? The diffusion gradient in the pelvis is high artery, low venous. If I raise the venous pressure up, I've changed the gap. Okay. So if you're going through menstruation and you've now shed your endometrium and you have these arteries bleeding, right?
Mhm.
If I have a lot of pressure in the venous system, I'm not allowing that blood to leave the uterus quickly. It's being congested. So even if your arteries spiral shut closed, they're still bleeding on the venous end because you can bleed from two sides. You can bleed from the arterial end or the venous end.
That's so
When
interesting.
you,
Yeah.
yeah.
Because I
So
don't
when
normally
you,
think of menstruation from that level of like the vascular tissue.
yeah, so I have.
Yeah.
So when you think about when you think about how you cut yourself or your average scratch or anything your kids have, 99% of the time you're really just seeing the venous bleeding, which is
Mm.
why if you hold pressure too long and really, really hard, you'll take it off and you're still bleeding. It's because
Right.
actually you didn't let blood go through and let clotting factors occur because you actually compressed it so much that nothing was getting through, right?
Got it.
When you deal with arterial bleeding, that's appropriate. When you deal with venous bleeding, you just need enough to get the bleeding to stop, and then the body will build clotting factors.
Right.
Well, in theory, at least in my mind, it makes sense that if you shed your endometrial lining and the arteries, the little spiral arteries come out and they feed the endometrium. When the endometrium drops off through each cycle, these spiral arteries are called spiral arteries because they look like springs and they spring back and they basically stop bleeding.
Mhm.
But there's still a venous component. And I think it's the venous
Mm.
component. If it's pressurized, and it doesn't take a lot of pressure. I mean, in a normal person lying flat, you expect about, 1 to 5 millimeters of pressure. You can get in a venous system, 20, 30 millimeters of pressure. Congestive heart failure patients would suffer from the same type of pathology. Um, and so you would expect, well, you have an exploited segment of tissue that's been essentially cut, right? You can clot all you want, but you're going to continue to bleed, but on the venous end. So we see, I think, longer bleeds, heavier bleeds, clottier bleeds,
Yeah, and
things of this nature.
in the context of endometriosis and adenomyosis, that all overlaps. So it's so easy to go undiagnosed from a vascular perspective if you have these conditions.
Yeah, yeah. But
Yeah.
also things like this, fibroids, cancer, tumors can also bleed, which is why it's important. You have to go through the thorough. So really, in the end, this becomes kind of a diagnosis of exclusion. You've ruled out cancer. You've had a history of some people have lesions and then the OBGYNs treat them and clean them up, right?
Yeah.
A classic pattern is you have very bad symptoms. You go, you get your study by your OBGYN, they put a scope in your belly, and they're like, oh, you had endometriosis, but it's not as bad. You hear this story a lot. They'll say I had it, I have terrible symptoms, but they said I'm a grade one. It wasn't bad. They didn't think there was anything to treat, and yet they're still very, very symptomatic. The
Hmm.
problem is when they put the scopes in, the abdominal lining is covered with this pink tissue called peritoneum.
Yeah.
And I think it is wildly difficult to see through it. And you're looking at things and you do not see these veins. The
Yeah.
very bad patients, the doctors, you'll get these crazy comments like, oh, you had a lot of varicose veins in your pelvis.
Mm.
Or the transvaginal ultrasounds that are notorious. You'll get two reads. You'll get some where they dictate in the body or the technical component, oh, some varicose veins. And then in the summary, they don't put anything, or
Yeah.
sometimes they make this offhanded, just in passing comment on these. So it's been seen, it's just been underappreciated.
Yes, and also correct me if I'm wrong, but my understanding is when someone does go in for their endosurgery, the position that they're laying in on the table doesn't allow for the veins, if they are varicose, to be as apparent as if they were laying flat. Is that correct?
Yeah, sometimes they flip you upside down and are
Yeah,
draining your pelvis.
that's
Yeah,
it. Exactly. So I think also that's why it may also get missed unless it's super enlarged and super obvious. No one's
yeah,
really
exactly.
looking for it. They're looking for the endometriosis lesions. Yeah, very, very interesting. So I just wanted to jump on the chat box real quickly, um, because oh, okay. Can I ask you, can I start asking you questions? If that's okay?
You've been asking the whole time.
I
Why
mean,
stop now?
the questions from our chat box. I'd love to go
Yeah,
through
go
them.
ahead.
Is this presenting in both men and women or predominantly women with EDS or hypermobile EDS?
You very rarely see men. I don't understand why not. I do think that the hormones in the pregnancy matters. In my practice with POTS, there's 7 guys out of hundreds and hundreds of women. You do see a couple men now and then, but they're very infrequent. This is leading to the whole theory of when you're starting into POTS and you're starting into dysautonomia, there's got to be a neurologic component to this. But you do see some of these consistent patterns even in the men with POTS. So I think that is still an area of exploration that I think will take some years of really deep neurology and
Yeah,
science
I
to figure out.
and also from a hormonal standpoint, the estrogen and progesterone certainly can have roles to play in the chronicity of this as well, especially if
Mhm.
you've already got a predisposition to estrogen dominance or conditions like fibroids or endo, where we have all sorts of hormonal dysregulation. So, yeah.
Yep.
Um, Someone just said, will this be recorded? I have a gal pal, former pro dancer actor that has Nutcracker and zero professionals in Canada to assist her. This is definitely going to be recorded. It's going to be on YouTube as well, so um you can give her the link. But Dr. Hacker, do you
Yeah,
have
we just had someone in Canada just fly down and get treated 2 weeks ago.
where you
Just
go?
came in and we did the whole thing. Yeah, and pro dancers, we do see a lot of dancers, people who were dancers, who did ballet, who were fine, and then just, they hit their 20s and just kind of fell off the wagon or got knocked off from this whole pathology. We see this quite often. I think the way that they are trained, they just end up being so thin and narrow, they get very bad nutcracker phenomenon,
That's so
and they become
interesting.
some of them, yeah, very symptomatic.
And then if you think a lot of these dancers are probably also very hypermobile too.
Yeah, yes, exactly. So
Yeah.
I think what you're seeing is kind of the convergence of multiple things at once, and it's just been missed.
Yeah, yeah. Jenny, oh, hello. All right, so we've got a question from Jenny. She's been diagnosed with NCS, Nutcracker, and PCS, pelvic congestion. How do you feel
Mhm.
about stenting for Nutcracker? Oh, I know this is your area of expertise. I have been told there's a high risk of migration, especially for EDS patients. I was also told to only treat right side with PCS for now and see if that gives me relief for POTS and leg heaviness.
Mm. So if you go back to the anatomy, treating the right side for pelvic congestion doesn't make any sense because you're actually blocking the outflow of all your venous stuff. So if you go back to our imaging, we want to treat everything on the left side, right? Because you have compression. So uh, if you're treating the right side, you're jumping ahead of the problem, and now you're preventing the blood from leaving the pelvis. So I would argue with that strategy is backwards.
Mm,
And so, as far as stenting, I'm just got the papers. I'm chugging through the data. I have 1 year data. We've treated 50 people with renal vein stenting alone, and we've only had one migration, and it was in someone who had a neurologic disorder. Who did a lot of like grunting and was constantly like bearing down and blowing their venous system up.
mm.
That was the only stent migration. We've had no perforations of the renal vein. We've had no thrombosis of the renal vein. And we have a 90% follow up at 1 month. So um, now that's part one of the comment.
Hmm.
Part number two is it really matters how you do the stenting. And part three is it really matters what stent you use. And
Mm,
so, in my experience, there's only one stent you can use. It's called a Viabond stent by Gore. It's covered in PTFE, and they make it it's in 13 millimeters. And so, it's a very large stent on the inflow side. It's a very large stent on the outflow side, and it gets crushed in the middle. But it's so big, it exerts enough radial force that at base by pinch mechanism, it's not going to move. Has good data in dialysis patients in the venous system. But migration is always a risk. In our
Wow.
guy, it migrated up into his heart, through his heart chambers, into his lung, and stayed there, and it will never move again.
Oh
It's
my
made out of
gosh.
inert, yes, but it is
Wow.
a very real risk. But your alternative is do nothing, get cut open and get a renal vein transposition, which, by the way, only has an 80% 1 year primary patency rate, meaning that at 1 year, only 80% of the people who've had it cut, moved, and sewn closed are going to keep it open like that. The rest are going to need a stent.
Mm. Can you explain that? Do you have the mouse? You have mouse access. Can you show us on this diagram?
Sure.
Because
So,
obviously the renal vein is just there. So what happens in transposition surgery?
sure. So, if you can imagine right here,
Hmm.
you see it where the black dot is, you
Hmm.
have this compression. So, what we'll do is, and this is a procedure I technically can do, I don't do it because I think it's kind of archaic, but you make an incision in the belly from basically the xiphoid down to the belly button. You push all the organs away. You open up the retroperitoneum. This is the space we go into. This is how we fix open abdominal aortic aneurysm. So I'm very comfortable in this space. You then have to find the renal vein, put a clamp on it, and sew it shut so you don't bleed out. Then on the other side, you take that vein and you either swing it up to the spleen or you bring it down onto the inferior vena cava and re-sew it. But every time you sew something, you're now putting something on tension and
Mm.
stretch,
Mm.
right? So you have to sometimes mobilize the kidney, which can lead to kinking of the ureters. And again, 20% of people will need a stent after this surgery to keep that anastomosis open. That's number one. The other one is a kidney transplant, where they take your own kidney out and they just transplant it into your pelvis so that you don't have all this tension. But now you have to cut the artery and the vein and the ureter and retransplant all three. I'll take stent.
Yeah. Yeah, it's just listening to it makes me feel uneasy, but I mean, this is what most people are getting for Nutcracker, right? Majority of
Correct,
people.
correct,
Um,
correct.
I don't know
Well, the thing
anyone
is
else.
this, you could still get it if you have a stent. You can go back in, take these stents out, and then,
So
if you're getting an
stents
open
can be
operation,
removed?
the Viabond can.
Okay.
If you go back to the old data, you have to understand I've really been perfecting the surgical technique to the point where I can do this in an office. In the United States, I can't do it in the office because of the cost of the stent. But from a technical standpoint, you can. Prior to this, we were using what we call bare metal stents. And I've been waiting for the time, but I was going to do an Instagram demonstrating these stents, the types of stents, what they look like. But the
Mm.
average stent is like an open mesh set of metal,
Mm.
and the body can grow through it. But
Oh,
also how they were deployed, or usually when they were small enough to deploy, they were undersizing the stents, which leads to migration risk.
yeah. So how big is the
And
renal vein? How thick is it? Like the lumen?
oh, well, what you'll see is when we do the intravascular ultrasound, an average POTS compression syndrome nutcracker person has a renal vein between on the left side of the compression, anywhere between 13 millimeters, 14 millimeters would not be an uncommon size. And normal might be like 8. And then you get this compression, like full blown compression, and then
Mm.
it opens back up to the inferior vena cava, and an average vena cava at that level might be around 24 to 30 millimeters.
Okay. So the you're saying that this stent then kind of like grabs onto the tissue and stays there, really? When
You
it
kind
gets
of put it in and you just kind of boing, spring it open, and then through radial force. The Viabond has some like texturing on the outside, which I think helps a little bit.
uh-huh.
It's also a little bit slinky. I've had people that are short, and we've had to do something called periscoping, where the stent comes into the inferior vena cava like this, or flops a little bit. It is not the world's most perfect thing, but we have seen no complications from it and just tremendous stories.
Yeah. Okay. Well, that's very interesting. I'm definitely watching this space because it's so unique, your approach to dealing with this.
Yeah,
Um,
it's an evolution, I guess.
yeah, yeah. We've got a question from Sarah. She's just asking if this can be spotted on a standard pelvic MRI. And would a standard radiologist
Uh,
see this?
So, a standard MRI, maybe not. I think you have to understand how MRIs are phased. They basically use radio waves and then they use a big magnet and they pop down the electrons and they use all these polar alignments and then they use computers to protocol them. You'd have to very specifically have it in a venous phase. So it's looking at the venous blood flow. Otherwise, the MRI is going to be looking for soft tissue only. Um, but some would argue that a venous phased MRI would be the gold standard to diagnose pelvic veins or other venous conditions. They're quite expensive, and I mean, if you're from various places around the world, you may not have access to an MRI. Just may
Yeah.
be difficult to get to in a timely fashion.
So an
Um,
ultrasound would be better, no? Like measuring the size of the vein
yeah,
and velocity and all that.
yeah. So the certainly a transvaginal ultrasound, I would argue, would be almost like a gold standard because you're either going to see varicose veins or you're not. And if you were, oh my gosh, I'm going to have you talk to the group really quickly while I answer an important phone call.
Okay, sure. Sure. Go for it. Go for it. Um, all right. I'm just gonna stop this share because there's another question here. Blood pooling. I'm gonna see if I can answer your question, Amy. I may not. Blood pooling in the lower legs, leg pain. Yes, absolutely. Throbbing. Um,
I'm
we
back.
hold. Oh, okay. That was very quick. Um,
Now you have to answer the phone when the people call it. So sorry
yeah,
about it.
for
Go
sure.
ahead.
No, that's fine. Amy's just asking if blood pooling in the lower legs and leg pain and throbbing is a symptom. I'd say absolutely yes.
Yeah.
We've been told by a vein surgeon this would not be a symptom. And it would be the dysautonomia causing the blood pooling and leg pain. I think it's the other way around, to be honest. But
So without disrupting the colleague, I think you very could very simply say, okay, symptoms of venous congestion and dysautonomia and venous reflux can cause leg pain, leg achiness, heaviness, discomfort, right? A simple venous ultrasound will demonstrate whether or not you have venous reflux. If you have no venous reflux and you have these symptoms, yes, more pelvic symptoms could be resulting in delayed or slowed flow, right? You have to kind of piece it together.
mhm.
So you have to take the body and break it up into segments. Um, sounds like maybe the surgeon maybe is only getting partial information, or if they're old, ask them how much gray hair they have. You know, they may not be thinking like this.
Um, it would be dysautonomia causing the blood pooling. So, but wouldn't the blood pooling also then cause the dysautonomia symptoms? That's what I'm trying to say. Absolutely.
That's some of them. I mean, you have to understand the legs are
Yeah.
essentially the oil pan of the body. So if you run your car, very little oil is actually in the pump trickling down the engine. It's all sitting in your oil pan, right? All 5, 7 liters. Well, seven's probably too much. We'll call it five, right? You
Mm-hmm.
might have a liter in circulation. In your body, 70% of your blood is stored in your legs. And when you're active or you get up, you move it into the body, you utilize it, and then it kind of collects back in the venous system. So if you have dysautonomia where you're either not properly mobilizing that due to poor tone, or if you have May-Thurner syndrome and you have a physical compression and you can't get that blood rapidly into your circulation, you're going to experience those dysautonomia symptoms, that tachycardia, that lightheadedness, that rush, right? Because you physically are pumping the blood out and you're ineffectively getting it back. And so I
Yeah.
think that's one of the presentations people will see.
Yeah. Yeah. All right. Oh, Caro. Okay, I will we'll give this one a try. It's more neurological, regarding seizure-like episodes and endo PCOS. I recently learned of catamenial epilepsy. How hard is it to determine this? Would we know if a neurologist would be able to determine if there is endo in the brain? Um, hmm. I think this is a little bit out of my scope from a neurological perspective. Um, the imaging, as Dr. Hacker mentioned before, MRI looks for soft tissue. I definitely think that would be the way to go if you suspect endo in the brain. But yeah, I'm sorry. I don't know how to answer this well. So I think you'd need to speak to an endo specialist as well as a neurologist to rule out to figure out what these episodes actually are and whether or not you have any radiological evidence of endo in the head, in the brain. Um, okay, here we go. Hang on. Um, have you seen in female patients with EDS, yet to be formally diagnosed, um, undiagnosed ADHD, PTSD, medical trauma, adenoendo, PCOS, fibroids, um, miscarriage? Are you able to see this chat box?
Ooh, let
It's a
me see
very
if I
long
go to
question.
it.
I'm just trying to, yeah, if you click chat. Um,
There's this delay. So I hit chat. Oh, okay, here we go. Lots of things, lots of words.
yeah, I'm
This
trying
is
to,
from Mandy, correct?
yeah, yep. Ovary was removed, left leg nerve
Hmm.
damage still, and my left pubic bone still feels as if it's been smashed to smithereens. Lipoma. Oh gosh, hang on. Does this sound like it could be vascular?
Yeah, so actually there's several things going on. So if you do have a lot of like the endometriosis, you can develop adhesions to the
Yes.
organs. So you
Yes.
can get the ovary sticking to the bowel.
Yes.
If you get a couple folds of adhesions, you can get a sense of fullness. And it can have a weird pattern because as gas is transferring through the intestines, you may get a tugging. If you get a recurrent tugging or fullness in that left lower quadrant, that's probably some set um, adhesive uh, patterns, right? The pubic bone that feels abnormal is most likely due to a referred pain. So
Mm-hmm.
there's nothing wrong with it. Your body is sensing this.
Mm-hmm.
This is the other problem with this region of the body is it shares kind of one or two ganglia. And so there's a lot of referred pain, a lot of symptoms that you can't really like put your finger on because they make no sense when you describe them to people, right?
Yeah.
For these very complex questions, we've set the bar very, very low. This is why I think we've been finding it. We just have people come in, we do the venogram, or you could start off with the transvaginal. If you see a lot of varicosities, then you probably may have this on top of the other things. The
Yeah.
key is if it's not really bad, try not to get into the abdomen because
Yeah.
these are really tricky and can lead to a lot of complications.
Yeah, because she said specifically a feeling of heaviness in her left thigh. So,
Hmm.
do
Yeah.
specific symptoms in individual legs correlate to a vascular compression?
Yeah. Left side. The
Yeah,
Mather, it's classic. Yeah.
yeah. So definitely it would be worth ruling it out. Um, and as Dr. Hacker said, just starting with an ultrasound is not a bad idea.
Yes. Yes.
Um, but could they see the iliac vein from a transvaginal ultrasound?
No, but they would see it from a trans abdominal ultrasound,
Yes.
especially specifically if you said, "Hey, I want to rule out Mather." Sometimes they set the criteria bar a little too high.
Hmm.
So, um,
Do you know anyone in Canada who she
yeah,
can,
who does this?
or to just get the ultrasound, vascular?
Is that in Vancouver? Is that what she said? She's
Yes.
in
Yeah.
Vancouver. So in Vancouver, if you wanted to go down to Washington State, which I don't think is that far,
Yeah.
right, from Vancouver. That's because that's in there's a very big institution of vascular, huge guys out in Washington State, big vascular practice. But even if you just asked a vascular surgeon, if you developed a rapport with them, right, you said, "Hey, I need the following ultrasounds. I need an abdominal ultrasound to rule out May Thurner.
Hmm.
I need a transvaginal to rule out pelvic congestion." You just need to tell them do these and comment specifically on these two things, you'll know pretty quickly, right?
Yeah.
And
Yeah. I mean,
most,
I didn't even need to do a transvaginal. They just did an abdominal, and they could see it straight away. Massive, massive veins.
yeah, yeah, yeah.
So,
So that. That's who I would recommend in Vancouver. I don't know a lot of Canadian doctors, so
Yeah.
I know there's a couple though.
Um, yeah, I'm sorry. I would just look up in your region where you can see vascular specialists and go from there. But maybe you need to go to the States for a treatment if you need the treatment. Um, Unfortunately, many doctors won't listen and refuse to order proper tests. I know. Being your best advocate is one of the hardest jobs in managing chronic illness.
Yeah. I
Yeah.
think if the way you can convince other doctors through data and research, and you say, "Hey, listen, I understand this is an edgy topic. Humor me. Here's a paper. There's a doctor who has a video. I have a 1 hour video that describes all of this from the Bendy Bodies podcast. You
Yes.
have this, and soon we'll have some papers and data. We have that gentleman that you introduced me to, the other
Yep.
doctor. There's the paper now from the Lancet, right,
Yes.
that just came out last month. I mean, there's enough data out there that, if they're not listening to the reported data from the physicians, right, and you're saying, I think this may be what I'm doing, though, then they're not really trying to help you at all.
Yeah. Yeah. And unfortunately, it takes second, third opinions till you finally get heard sometimes. So I know, I get
Yeah,
it. I've walked it. I'm still walking it, especially when you're a bit complex. You don't quite fit in the box. It makes it
yeah.
really, really complicated. Any last questions before we wrap up, or anything else you'd like to add before we wrap up, Dr. Hacker?
I think it was a really great honor to be here and answer some questions for people. I hope you guys all found it informative.
Yeah.
Basically, aside from this video, the Instagram, I think just spend some time reading those videos.
Yep.
If you go to our website, there's some links to some previous podcasts. These are
Yes.
all meant to be educational. These are all meant to help take people from no knowledge or trying to piece all the symptoms together to say, hey, does this fit for me?
Yes.
And then this, yeah,
So
this is
how
a
can
difficult
people find
space.
you or access obviously I shared your Instagram earlier in the
Yeah,
video, but if you don't mind just letting everyone know, and I'll put the link as well underneath the YouTube. Okay, that link.
yeah,
Okay, I'll pop that in the link
yeah.
in the
So
YouTube.
that's our website for our business, right? People
Yeah,
can just kind of click through it and
yeah,
you got to search just a little bit.
yeah.
Like I said, I'm not in charge of all the IT stuff, but
No,
also if you do, what is it?
Bendy Bodies podcast.
Yeah, Bendy
Link.
Bodies and Dr. Hacker. I think that one will pop up.
Yeah,
And that's a 1 hour discussion on like all the anatomy.
yeah.
So the
Perfect.
whole thing. So hopefully that
Yeah.
helps people out.
Yeah. So, oh, we've got many thanks on here. Thank you. Thank you all for attending. And for those of you watching on replay, it's been a pleasure. It's so good to highlight. I know it's Endometriosis Awareness Month, and we know endo in and out now, but I believe this is an area that we need to shed a lot more light on in endo patients. So, thank you so much, everyone, for being here, and happy Endometriosis Awareness Month. Thank you, Dr. Hacker. Have a wonderful evening and
Thank
take
you.
care. Bye bye.
Yes, thank you. Take
See
care.
ya. Bye.